Welcome in Pediatric Lecture Series. Myself, Dr. Sunil Nathamhaske, Professor in Pediatrics and Dean in Dr. Vithalrao Vikhe Patil Foundation's Medical College, Ahmednagar in Maharashtra. Today, in Pediatric Lecture Series, this is the 15th lecture on very important topic concerned with the child, and it is the childhood nephrotic syndrome. In practice, we very frequently come across these cases either in OPD or IPD or sometimes as an emergency. Now we will see what is the definition of nephrotic syndrome. As such, nephrotic syndrome is not a disease. It is the collection of symptoms which are particularly related with the kidney damage. It can affect the people of any age, but mostly it is first diagnosed in the age group of 2 to 5 years of the age. Nephrotic syndrome commonly affects the boys than the girls. Around 1 in every 50,000 children are diagnosed with this condition in each year. It tends to be more common in families with a history of allergies or those of an Asian background, but still the reason is not clear. That means nephrotic syndrome, mostly it is the idiopathic. The pathophysiology of nephrotic syndrome is this: like kidneys are filled with tiny blood vessels, which is commonly known as glomeruli. And as such, the blood moves through these vessels, these glomeruli. Extra water and waste products are filtered into the urine. Protein and other substances that body needs stay in the bloodstream. But in nephrotic syndrome, when these glomeruli are damaged, they can't properly filter the blood. Damage to these blood vessels, which allows the protein to leak or pass into the urine. Albumin, which is the main component of the protein, which is lost in the urine. This albumin helps to pull extra fluid from the body into the kidneys, and this fluid is then removed in the urine. Without albumin, body holds onto the extra fluid, and which in turn causes the generalized edema over the legs, feet, ankles, and the face. In short, there is alteration in glomerular basement membrane, which leads to the altered glomerular protein permeability, which causes increased loss of protein in the urine, and decreased colloidal osmotic pressure, which in turn causes the edema and decreased vascular volume. This is the in short pathophysiology of the nephrotic syndrome. Now we will see the clinical features of nephrotic syndrome. There are few very important components which defines the nephrotic syndrome. First out of that is the large amount of proteinuria. If you see by definition wise, more than 3.5 gram per 1.73 meters square of body surface area per day, or more than 40 milligram per square meter body surface area per hour in children is the passage of the proteins in the urine. Second characteristic is the hypoalbuminemia. Albumin level is less than 2.5 gram per deciliter. Third is the hyperlipidemia. Lipid profile is increased. Fourth one is there is an edema which starts from the face and it starts towards the legs. That is a generalized edema, also known as anasarca. Next is the lipiduria. Lipids are also passed in the urine, but it is not the essential feature for the diagnosis of nephrotic syndrome. Likewise, hyponatremia also occurs in nephrotic syndrome. But to define the nephrotic syndrome, proteinuria, hypoalbuminemia, hyperlipidemia, and generalized edema are the essential requirement for the diagnosis or definition of the nephrotic syndrome. This hyperlipidemia or raised lipid level is due to hypoproteinemia, which stimulates the protein synthesis in the liver and in turn causes the increased production of the lipoproteins. Second mechanism is lipid catabolism is decreased due to lower level of lipoprotein lipase, which is the main enzyme involved in lipoprotein breakage. That's why because of this hypoproteinemia and lipid catabolism, which is decreased, causes the hyperlipidemia. Now we have seen this excess fluid in the body, that is the edema all over the body, or also known as anasarca. It is mostly due to the serum hypoalbuminemia. decreased serum albumin. This lower serum oncotic pressure causes fluid to accumulate in the interstitial tissues. Sodium and water retention aggravates this edema. This may take several forms. Initially, there is puffiness around the eyes, characteristically in the morning. This edema is pitting over the legs, fluid in the pleural cavity, which causes pleural effusion, more commonly associated with excess fluid in the pulmonary edema, fluid in the peritoneal cavity causing ascites, and lastly is the anasarca, that is generalized edema throughout the body. Other characteristic of nephrotic syndrome are most of the people with nephrotic syndrome are normotensive, normal blood pressure, but rarely there may be hypertension. Second characteristic is anemia. This anemia is iron resistant microcytic hypochromic type, which is present due to transferrin loss. Third, there is dyspnea due to pleural effusion or due to diaphragmatic compression leading because of ascites. Then, increased erythrocyte sedimentation rate due to increased fibrinogen and other plasma contents. And some peoples may notice foamy or frothy urine due to lowering of surface tension by severe proteinuria. Actual urinary complaints such as hematuria, oliguria, these are uncommon in nephrotic syndrome, which are very common in acute glomerulonephritis. Also, nephrotic syndrome patient may have manifestation of underlying disease, for example, rash associated with SLE, systemic lupus erythematosus, or neuropathy associated with diabetes. Examination should also exclude other causes of gross edema, especially cardiovascular or liver system. Then, Murex nails, that is a white lines leukonychia that extends all the way across the nail and which lies parallel to the lanula, may be seen in nephrotic syndrome. Now, we'll see certain signs of the nephrotic syndrome. First one is the proteinuria. We have seen it is more than 3.5 gram per 24 hours per body surface area of 1.73 meters square or greater than 40 milligram per hour meter square in children. Ratio between urinary concentration of albumin and creatinine can be used in the absence of 24 hours urine test for total protein. This coefficient will be greater than 200 to 400 milligram per millimoles in nephrotic syndrome. This pronounced loss of protein is due to an increase in glomerular permeability that allows protein to pass into urine instead of being retained in the blood. Under normal conditions, 24-hour urine samples should not exceed 80 milligram or 10 milligram per deciliters of urinary protein. Now, second feature after proteinuria is the hypoalbuminemia. Albumin level is less than 2.5 gram per deciliter, which exceeds liver clearance level. That is, the protein synthesis in the liver is insufficient to increase the low blood protein levels. This edema is thought to be caused by two mechanisms. First, because of hypoalbuminemia. Second, it is the albumin which causes direct effect on the epithelial sodium channel on the principal cells, which ultimately lead to reabsorption of sodium and water. Hyperlipidemia, there is an increase in synthesis of low and very low density lipoproteins in the liver, which are responsible for the transport of cholesterol and triglycerides. There is also an increase in liver synthesis of cholesterol. Then is the thrombophilia or hypercoagulability. There is a greater predisposition for the formation of blood clots because of decrease in level of antithrombin 3 in the blood due to its loss in urine. Then is the lipiduria or loss of lipid in urine. It is indicative of glomerular pathology due to an increase in filtration of lipoproteins. These are the clinical features of nephrotic syndrome. Now we will see the types of nephrotic syndrome according to its etiology or causes. Broadly, nephrotic syndrome is of three types: primary nephrotic syndrome, secondary nephrotic syndrome, and third one is the congenital nephrotic syndrome. Both primary and secondary nephrotic syndrome can occur in children. Primary nephrotic syndrome compared to secondary type is more commonest type in children. Now its etiology is vary according to primary, secondary, or congenital type. Nephrotic syndrome If it is congenital, it is mostly Finnish type of congenital nephrotic syndrome. If it is secondary, it may be due to infection with hepatitis B or C, HIV, malaria, syphilis, toxoplasmosis, certain drugs like penicillamine, gold, NSAID, then interferon, mercury, lithium, then certain allergic disorders are associated with malignant diseases like lymphoma and leukemia. Whereas idiopathic nephrotic syndrome or primary nephrotic syndrome is classified according to the histology. Out of that, first one is the minimal change nephrotic syndrome, common in children, where the nephrons appear normal when viewed with an optical microscope. Just there is a lesion under the electron microscope. But in this case, there is a marked proteinuria. This is very common type of nephrotic syndrome in children. Second type is the focal segmental nephrotic syndrome. It is the commonest nephrotic syndrome seen in adults, where the appearance of tissue, where there is a scarring in the glomeruli. The term focal is used as some of the glomeruli has scars, while others appear as intact. And the term segmental refers to the fact that only part of the glomerulus suffers from the damage. So this is a focal segmental glomerulosclerosis common in adults. Third one is the membranous nephrotic syndrome or membranous glomerulonephritis. There is inflammation of the glomerular membranes which causes increased leaking in the kidney. This autoimmune mechanism is suspected in this membranous glomerulonephritis. Then fourth type is membranoproliferative glomerulonephritis. There is inflammation of the glomeruli along with the deposit of antibodies in the membranes, which makes the filtration difficult. And fourth type under this primary heading is the rapidly progressive glomerulonephritis. It usually presents with a nephritic syndrome. A person's glomeruli are present in a crescent moon shape, and it is characterized by clinically rapid decrease in glomerular filtration rate, at least by 50% over a short period of the few days to 3 months of duration. All these 5 types of primary nephrotic syndrome are considered to be diagnosis of exclusion, that is diagnosed only after secondary causes have been excluded. Just now we have seen the secondary type of nephrotic syndrome. Its causes like diabetic nephropathy, systemic lupus erythematosus, sarcoidosis, syphilis, hepatitis B, HIV, amyloidosis, myeloma, or certain drugs like gold salts, penicillin, or a captopril. After primary and secondary type of nephrotic syndrome, third type of nephrotic syndrome is congenital nephrotic syndrome. It usually caused by inherited genetic defect or infection shortly after birth. For the condition to be passed into the child, both parents must have a healthy copy of a gene and a faulty one. This means that they do not have nephrotic syndrome themselves, but there is a 1 in 4 chance that any child they have will develop a condition. That means 1:4 chances are there which manifest in first 3 months of life. This congenital nephrotic syndrome is characterized by high level of proteinuria, low level of protein in the blood, and generalized anasarca. This congenital nephrotic syndrome is a heterogeneous Finnish form caused by NPHS1 mutation or ARNPHS2, PLCE1 mutation, or intrauterine infections. Histopathologically, there are microcystic dilatation of proximal tubules in NPHS1 type. In congenital nephrotic syndrome, elevated levels of alpha-fetoprotein are seen in the maternal serum and amniotic fluid if you do antenatal screening. And treatment involves frequent albumin infusion, and lastly is the kidney transplant. Now, overall complications of the nephrotic syndrome. First, commonest complication of nephrotic syndrome is thromboembolic disorders due to low levels of blood antithrombin 3 levels, which causes leakage into the urine. Then second complication is infections. It is because of leakage of immunoglobulins from blood, loss of proteins in general, and the presence of edematous fluid, which acts as a better breeding area for the infections. And the most common infection due to nephrotic syndrome is peritonitis. Then there is infection of the lung, skin, urinary tract, meningoencephalitis, and most serious is the septicemia. And this infection is mostly caused by Streptococcus pneumoniae or Haemophilus influenzae. And very commonly, if there is ascites in nephrotic syndrome, spontaneous bacterial peritonitis develops in the child. Next complication is acute kidney failure due to hypovolemia, then pulmonary edema, also hypothyroidism due to deficiency of thyroglobulin transport protein thyroxine due to decreased thyroid binding globulin, and also vitamin D deficiency occurs in nephrotic syndrome. Then hypocalcemia due to lack of 25-hydroxycholecalciferol, microcytic hypochromic anemia. It is iron deficiency anemia caused by the loss of ferritin, and treatment here you have to notify that it is iron therapy resistant type of anemia. Then is the protein malnutrition because of loss of protein, growth retardation since it is a chronic disease, and very commonly because of treatment of nephrotic syndrome with steroids causes a Cushing syndrome. Now, after these complications, we will see how to diagnose the nephrotic syndrome. The two screen parameters are very important. One is the urinary screen and second one is the blood screen. In urine, you have to test the 24 hours urine analysis, see the high levels of proteinuria, that is more than 3.5 gram per 1.73 meters square per 24 hours, with the help of dipstick test for albumin. Then you have to see the urine albumin to creatinine ratio. If it is high urine albumin creatinine ratio, it indicates kidneys have leaking large amount of albumin into the urine. And also along with this urinary protein, you have to see the urinary cast, which is common in active nephritis. With this urine analysis, next one is the blood screen. You have to see the hypoalbuminemia, that is albumin level, if it is equal or less than 2.5 gram per deciliter. Normally it is 3.5 to 5 gram per deciliter. Then creatinine clearance test, which evaluates the glomerular filtration capacity, also you have to assess. Then urea level and electrolytes you have to assess in order to evaluate the kidney function. Then lipid profile, because of hypercholesteremia, elevated low density lipoproteins are common in nephrotic syndrome. After urine and blood, you have to check the kidney biopsy. Usually this kidney biopsy is only indicated for children who are corticosteroid resistant, as the majority of them suffer for focal and segmental glomerulosclerosis. Then lastly is the ultrasound of the kidney. In children having nephrotic syndrome, this ultrasound shows hyperechoic kidney without demarcation of the cortex and medulla. Now, biomarkers of this idiopathic nephrotic syndrome. These biomarkers represent a non-invasive approach in diagnostic nephrology, as these biomarkers can be used in the prediction and prognostic evaluation of the disease, as well as in differentiating steroid-resistant nephrotic syndrome from steroid-sensitive nephrotic syndrome. Some of the diagnostic biomarkers for this idiopathic nephrotic syndrome are adipokines, neopterin, beta-2 microglobulin, and NAG, that is N-acetyl beta-D-glucosinamides. These are diagnostic biomarkers. Whereas urine vitamin D binding protein, UVDBP, and alpha-1 beta-glycoprotein, these are able to differentiate steroid-resistant and steroid-sensitive nephrotic syndrome. This NAG, N-acetyl beta-D-glucosamidase, and beta-2 microglobulin could also predict steroids responsive and renal outcome in steroid-resistant nephrotic syndrome. Next marker, elevated serum ADPN levels were documented in steroid-resistant nephrotic syndrome patients in relapse. That means it indicates the relapse. Serum neopterin levels were found to be significantly elevated among steroid-sensitive and steroid-resistant nephrotic syndrome patients with the active disease when compared to those in remission and control. That means it is found in active cases. Now, differential diagnosis of this nephrotic syndrome. Common features we have seen is the edema, which differentiate from heart failure and liver failure. Also, acute fluid overload, proteinuria, multiple myeloma also seen. Now we will see in short about causes of proteinuria, which are very common in nephrotic syndrome. This proteinuria is of two origin. One is glomerular and tubular. In glomerular, it is due to increased filtration. It is subdivided into three groups. Primary glomerulonephritis is the IgA nephropathy, minimal change glomerulonephritis, mesangial glomerulonephritis, focal segmental glomerulonephritis, MPGN. Whereas secondary type like diabetic nephropathy, SLE, amyloidosis, preeclampsia, infection with hepatitis B, C, HIV, post-streptococcal glomerulonephritis, syphilis, malaria, endocarditis, malignancy of the lung and GI, renal transplant reinfection. Drug-induced glomerulopathy like non-steroidal anti-inflammatory drug, heroin, lithium, and heavy metals. Whereas proteinuria may be due to tubular causes like decreased reabsorption, like hypertensive nephrosclerosis, uric acid nephropathy, interstitial nephritis, drugs like heavy metals. These are again divided into various causes like functional proteinuria or tubular proteinuria. We have seen tubular type. Now functional, there is no organic change in kidney tissue. It is usually less than 1 gram per deciliter and it is reversible. It is seen in strenuous exercise, fever, orthostatic proteinuria, thyrotoxicosis, severe anemia, and CNS lesions. Also, according to the site, this proteinuria can be divided like pre-renal causes in heavy exercise, fever, hypertension, multiple myeloma, eclampsia, renal causes like acute and chronic glomerulonephritis, renal tubular dysfunction, polycystic kidney, nephrotic syndrome. Third one is the post-renal, is seen in acute and chronic cystitis, tuberculous cystitis, etc. The list of these causes of proteinuria is very big, can be divided according to functional, tubular, according to origin, pre-renal, renal, or post-renal. Now, very important is the treatment. Treatment is divided according to symptomatic and specific. In symptomatic, the objective of this treatment is to treat the imbalances brought about by the illness, like edema, hypoalbuminemia, hyperlipidemia, hypercoagulability, and infectious complications. This edema is treated with the help of rest. Nutrition therapy is given total caloric intake of 35 kilocalorie per kg body weight per day. Do not consume more than 1 gram of protein per kg per body weight per day. Greater amount will increase the degree of proteinuria and cause negative nitrogen balance. Also, you have to restrict the ingestion of sodium to 1 to 2 gram per day, which means that salt cannot be used in cooking and salty food should be avoided in cases of nephrotic syndrome. Then medications for this edema. The pharmacological treatment of edema is based on diuretic medications. Like loop diuretics, commonly used is the furosemide. In severe cases, like physiological repercussions, scrotal prepubertal urethral edema, severe infections like sepsis and pleural effusion, the diuretics can be given IV. Also, sometimes a solution of 25% albumin is given in case of pulmonary edema. And in case of hypokalemia, you have to give the potassium as a dietary supplement. For hypoalbuminemia, you have to give the moderate intake of foods rich in animal proteins. Hyperlipidemia, you should ingestion of cholesterol should be less than 300 milligram per day. Avoid saturated fats such as butter, cheese, fried foods, fatty cuts of red meats, egg yolks, and poultry skins. Also, increase unsaturated fat intake like olive oil, canola oil, peanut butter, avocados, fish, and nuts. In severe cases of hyperlipidemia, which is unresponsive to nutrition therapy, you have to use the hyperlipidemic drugs like statins, hybrids, and resonance sequesters of bile acids. For thrombophilia, you have to use the low molecular weight heparin. And last is the infectious complications. You have to use the antibacterial drugs. Commonly used is the penicillin. Along with all these, you have to add the vitamin D and calcium. For better blood glucose control, if the patient is diabetic, you have to monitor it and treat accordingly. If there is a hypertension, you have to use the antihypertensive drugs like ACE inhibitors or other drugs suitable for that age and sex of the child. After this symptomatic, you have to use the specific treatment for kidney damage, and commonly used is the corticosteroids. The result is a decrease in proteinuria and risk of infection as well as resolution of the edema. Commonly used corticosteroids in nephrotic syndrome is the prednisolone given in the dose of 60 mg per meter square of body surface area per day in first treatment for 4 to 8 weeks. After 4 to 8 weeks of this 60 mg per meter square of body surface area of prednisolone, you have to decrease the dose by 40 mg per meter square for next 4 weeks. Those children who are suffering from a relapse or children who are treated with prednisolone 2 mg per kg per day till urine becomes negative for protein. Then you have to continue this prednisolone of 2 mg per kg per day in the lowering dose of 1.5 mg per kg per day for next 4 weeks. These are the two schedules. Either you give by per kg body weight of 2 and 1.5 or body surface area of 40 and 60 and 40 milligram per meter square of body surface area. Frequent relapses are treated by cyclophosphamide or nitrogen mustard or cycloserine or levamisole. These are the advanced drugs. People who can respond to prednisolone in number of different ways. Child with corticosteroid sensitive or early steroid responder, the subject respond to the corticosteroid within first 8 weeks of treatment. And this is demonstrated by strong diuresis and disappearance of edema, also by negative test for proteinuria in consecutive 3 samples taken during the night. Second responders are child with corticosteroid resistant or late steroid responder. Here the proteinuria persists after 8 weeks of treatment. There is a lack of response indicated by seriousness of glomerular damage, which could develop into chronic kidney failure. Then third responders are corticosteroid intolerant. Here the complications such as hypertension appear, weight gain, aseptic or a vascular necrosis of the hip, knee, cataract, thrombotic phenomena or embolism like complications occur with the help of steroid therapy. Fourth group is steroid dependent. Here the proteinuria appears when the dose of steroid is decreased or there is a relapse in the first 2 weeks after the treatment is completed. That means it is steroid dependent. After steroid, some of the immunosuppressors like cyclophosphamide has a role in recurring nephrotic syndrome where the corticosteroid dependent or intolerant people. In the first 2 cases, proteinuria has to be negated before treatment with immunosuppressors. That means proteinuria should be clear. The negation of proteinuria indicates the exact moment when the treatment with cyclophosphamide can begin. Treatment is continued for 8 weeks in the dose of 3 mg per kg per day. The immunosuppression is halted after this period. In order to be able to start this treatment, the child should not be suffering from neutropenia nor anemia because this will lead to further complications. A possible side effects of the cyclophosphamide is the alopecia. Complete blood count test should be carried out during the treatment in order to predict the possible infection. Along with the cyclophosphamide, levamisole, cyclosporine, tacrolimus, mycophenolate, or rituximab can be used. Very important is the vaccination in children with nephrotic syndrome. First important is the pneumococcal vaccine to be given. Then some children may also recommend the chickenpox or varicella vaccination between the relapse. Important is the live vaccines such as MMR, chickenpox, and BCG should not be given when the child is taking medication to control their symptoms. There are few terminologies which very commonly you come across in the treatment of nephrotic syndrome. First one is the remission. Remission means urine albumin is nil or a trace. That means proteinuria is less than 4 mg per meter square of body surface area per hour for 3 consecutive early morning specimens. This is the remission. Now relapse. Urine albumin 3 plus or a 4 plus, that is proteinuria more than 40 mg per meter square per hour for 3 consecutive early morning specimens after having been in remission previously. Then frequent relapse. 2 or more relapses in initial 6-month period or more than 3 relapses in any 12 months. Now next terminology is steroid dependence. 2 consecutive relapse when on alternate day steroid therapy or within 14 days of its discontinuation. Last is the steroid resistance. Absence of remission despite therapy with daily prednisolone at a dose of 2 mg per kg per day for consecutively 4 weeks. There are various regimes in the treatment of nephrotic syndrome. First one is the ISKDC, International Study Group on Kidney Diseases in Children. We have already seen it. Prednisolone is given in the dose of 60 milligram per meter square per day, maximum 80 milligram per day for 4 weeks. Then it is decreased to 40 milligram per meter square on alternate day, 4 weeks. Then long initial prednisolone regime, which suggests prednisolone is given 60 milligram per meter square surface of body surface area per day for 4 weeks. Prednisolone then decreased to 40 milligram per meter square of body surface area EOD for 4 weeks, then reduced by 25% monthly over next 4 months. In short, this prednisolone treatment in algorithmically we'll see in short prednisolone daily for 6 weeks followed by 6 weeks on alternate day. Then if there is a relapse more than 3 months and or infrequent relapse, you give the prednisolone daily until protein free for 3 days followed by 6 weeks on alternate day. Frequent relapse and or steroid toxicity, you start the cyclophosphamide. In second, after daily 6 weeks followed by 6 weeks alternate day prednisolone. If there is less than 3 months relapse or alternate day therapy relapse, you give the prednisolone daily until protein is free for 3 days or followed by 3 months on alternate day. Frequent relapse and or steroid toxicity, start the cyclophosphamide for 8 to 12 weeks. If there is a frequent relapse still on cyclophosphamide of 12 weeks duration, you start the cyclosporine. There are various regimes of giving steroids according to the personal experience, like ISKDC, German Nephrology Working Group, Ehrlich-Weierl syndrome, Ehrlich-Weierl study group. But as per personal convenience and experience, you can give this schedule. Commonly, we follow this ISKDC regime or IFA regime. Now, very important is child's care at home. Those who are having nephrotic syndrome, daily do the dipsticks to test the child's urine for protein. First time they urinate in the morning. The result of this deep test is the negative, that means 0 milligram of proteinuria per deciliter of urine. Trace indicates 15 to 30 milligram per deciliter. 1 plus, that is the 30 to 100 milligram per deciliter. 2 plus means 100 to 300 milligram per deciliter. 3 plus, that is 300 to 1000 milligram per deciliter. 4 plus, more than 1000 milligram per deciliter. It is suggestive of this dipstick result. If the dipstick shows 3 plus or more protein in the urine for 3 days in a row, this means child having relapse. If this happens, you have to immediately contact your consult the physician and start the steroids. Also, you should take the immediate advice if the child has come to contact with child having the chicken pox or a measles, child is unwell or having fever, child has a continuously diarrhea or vomiting. In this case, you have to immediately contact your pediatrician. Now, indications for referral to a pediatric nephrologist. If the nephrotic syndrome occurs below 1 year of age, there is a family history of nephrotic syndrome. If nephrotic syndrome is associated with hypertension, gross or persistent microscopic hematuria, impaired renal function, or extrarenal features like arthritis, serositis, or rash. There are complications like refractory edema, thrombosis, severe infection, steroid toxicity, resistance to steroid therapy, frequently relapsing or steroid-dependent nephrotic syndrome. In these all 5-6 conditions, you have to immediately refer the child to the nephrologist. Last but not least is the prognosis of nephrotic syndrome. The prognosis for nephrotic syndrome under treatment is generally good. It depends on the underlying cause, age of the child, and their response to the treatment. It is usually good in children because minimal change disease responds very well to steroids, does not cause the chronic kidney disease. Any relapse that occur become less frequent over time. The opposite occurs with mesangial capillary glomerulonephritis, in which the kidney fails within 3 years of the disease developing, making dialysis necessary and subsequent kidney transplant. In addition, children under the age of 5 generally have poor prognosis than the prepubescent, as do adults older than 30 years of age. They have a greater risk of kidney failure. Other causes such as focal segmental glomerulosclerosis frequently lead to end-stage kidney disease. Also, factors associated with poor prognosis includes low level of proteinuria, blood pressure control, and kidney functions. These are the major factors associated with the poor prognosis. Without treatment of nephrotic syndrome has a very bad prognosis. It can land up at any time into the kidney failure. This is in short about the nephrotic syndrome in child. We have seen the definition. It is not the disease. It is a group of the symptoms or a signs where they characterized by hypoproteinemia, proteinuria, hyperlipidemia, edema, along with its primary and secondary type, congenital nephrotic syndrome, its type, treatment, investigations, and prognosis. Thanks a lot. Thank you.